As a result of the global corona pandemic, teletherapy as a service model has experienced a major upswing. Health protection and the continued offering of therapy, despite the regulation of social distancing, were the driving force. In the meantime, the picture is changing again, as conventional face-to-face therapy is possible again. The term telemedicine is provision or support of healthcare services using information and communication technologies, where patients and healthcare providers are not present in the same place. The prerequisite for this is secure transmission of medical data for prevention, diagnosis, treatment and further care of patients in the form of text, sound and/or image, without direct physical contact. In teletherapy, the healthcare provider actively offers treatment from a distance. Thus, teletherapy is an individual form of treatment with simultaneous interaction between therapist and patient over distance. The simultaneous online presence of both patient and healthcare provider is of great importance, especially as this allows health insurance providers to charge correctly for the service. The due diligence requirements are the same as for direct physical contact. Here it is also due to the professional assessment of the speech therapist whether or what is specifically justifiable by means of therapy. The quality of telemedical therapy must not differ from face-to-face therapy. The question then arises from a professional standpoint. Should teletherapy even be allowed or offered at all? First of all, the exercise of health professions in Austria must take place personally and directly, that is to say, exclusively by a person entitled to do so. Teletherapy is permitted provided that the well-being, health and interests of patients are ensured in most areas of personal life. Teletherapy must take place, albeit virtually, in the same room and at the same time. And dangers from teletherapy must be excluded. No fixed period should be set for teletherapy, and this should not even solely be based on the current wave of the pandemic ending. Next, I'm going to give you some information about voice therapy recommendations. Although we know that the coronavirus is transmitted by droplet infection, speech therapy as well as phoniatric examinations should continue to be carried out urgently. The negative effects of non-treatment are too high. The authors warn of high risk of infection in voice therapy in a closed room as well as in aerodynamic measurements. ENT diagnostics entail a very high risk of infection. The authors recommend the online setting primarily for voice therapy. Here, no transmission of the coronavirus can take place. Guidelines recommend, where possible, moving to a larger room with good ventilation, ensuring both surfaces and materials are disinfected. Also ensuring a distance of 2 meters between patient and therapists. Singing or therapy of loud speaking should take place outdoors, if possible, to reduce the aerosol concentration. For ENT examination, as well as for speech therapy, patients should not remove their mask. Some studies show that the sound quality in objective measurement methods in the values jitter, fundamental frequency of the voice, and maximum phonation time are not affected by wearing their mask. The most important thing, according to the researchers, is that in face-to-face consultation, all persons present in the room should take a negative lateral flow test, preferably shortly before visiting the practice. Voice therapies with increased volume, such as Lee Silverman voice treatment or voice therapy after partial vocal fold paralysis, should also be avoided, as well as articulation exercises with high airflow speed, such as those caused by whispering. Exercises with the semi-occluded vocal tract exercises, such as chewing method or laxvox, as well as vocal currents from v and zh, produce fewer spit particles and are recommended in a face-to-face setting. s and sh produce significantly more air turbulence than when speaking loudly. Therapists should reconsider the length of the respective therapy, the recommendation being to hold shorter and more intensive sessions. In this study, using an online questionnaire during the first lockdown in Austria, 325 therapists from the field of physio, occupational and speech therapy took part. The researchers wanted to know what the therapist's assessment and use for teletherapy are. The majority said that with the onset of the corona pandemic and the need for teletherapy, its acceptance and use also increased. Furthermore, the survey showed that only a few % would like to stop teletherapy after the pandemic. Some would like to continue teletherapy in special cases. A broad majority wanted special therapy software for therapists, and the software should be certified by the state. More than a third wanted more scientific evidence, and a quarter wanted interdisciplinary training. Most wanted teletherapy to be legally anchored in the law. In many studies, the effectiveness of voice therapy has been proven, but some therapy sessions are often terminated early. This has many reasons, such as inflexible working hours without the possibility of time off, or the fact that rural areas are usually undersupplied. The journey to adequate therapy entails long distances and a greater amount of travel time. However, cancellations have the knock-on effect of cost for therapists. In the present study, Fu et al. Wanted to show that teletherapy provides broader access to therapy, is less likely to be cancelled, and results are maximized. The study participants had diagnosed vocal fold nodules and underwent intensive voice therapy in an online setting. Included were 10 women with mild to moderate voice disorders. The participants had to practice twice daily for 15 minutes on therapy-free days and once a day for 15 minutes on therapy days. The main component of the exercises was the large field of semi-occluded vocal tract exercises. All participants completed the study with a 100% attendance. Vocal fold function assessment revealed significant improvements across the group statistically, from baseline to post-treatment, for ratings of mucosal wave, vocal edge smoothness, and glottal closure. Post-treatment results revealed that all 10 of the participants were rated as having smaller nodule size when compared with pre-treatment results. In this study, the scientists wanted to find out whether teletherapy with flow phonation exercises is effective in patients with primary muscle tension dysphonia. 14 study participants were included, and these were divided into 2 comparison groups. They had 12 therapy sessions in 2 weeks. Significantly better were the perception and the subjective assessment by the study participants. Both groups were statistically equivalent. The acoustic and aerodynamic measurements also improved equally in both groups, but showed no significance. The equivalence of video therapy and face-to-face therapy for primary muscle tension dysphonia using flow phonation exercises has been proven. Furthermore, the equivalence of both treatment models for dysphonia and Parkinson's disease is demonstrated, in particular for the use of Lee-Silverman voice treatment. This is proven by a randomized controlled trial by Katharina et al. Each 18 participants included a group, and there were 16 units in 4 weeks. In this study, however, it was established that teletherapy units were cancelled less. There is a significant difference between the 2 groups. Teletherapy is used more often. The televoice study is a randomized controlled clinical trial with a direct comparison of video and conventional therapy in patients with functional voice disorders. 84 patients with functional dysphonia completed 8 sessions once or twice a week. Significant improvements before and after intervention showed both groups in the parameters of voice handicap index, maximum phonation time, jitter, shimmer, and speaking voice. There were no significant differences between the 2 intervention groups. The results show that the effectiveness of teletherapy is the same as conventional face-to-face therapy. When considering the negatives, the following parameters are mentioned in the studies: poor internet connection and the resulting time delay. The programs used are not GDPR compliant. Some therapists have reported problems with patients' attention due to possible distractions at home. Hands-on isn't possible, and also the high vocal load for the therapists is mentioned. In the studies, the advantages outweigh the disadvantages, these being: the primary objective of providing services via teletherapy is to overcome geographical mobility limitations on the part of patients. This means that non-mobile patients or living conditions that do not allow patients to come to therapy are recorded here. Medical reasons can also contribute to the fact that teletherapy is preferred. Furthermore, speech therapy services can be offered for those who otherwise have no access to therapy. The CO2 aspect is also a major reason. Long distances can be better overcome. Travel time and travel costs are eliminated. More flexible time management for speech therapists and patients. Appointments are not tied to resources such as practice premises or the like. Avoidance of therapy breaks and post-hospital care gaps. Consultation of specialists, diagnostics, although perhaps somewhat limited, is possible, especially in voice therapy. Fewer appointment cancellations. Therapy takes place in a patient's own environment and thus gives a new therapeutic input. Zoom meetings can be used very well in voice therapy, as sound settings can be made here. For voice therapy, it is very important to turn off noise cancellation, so every sound can be received and understood in an effective manner. Outlook for the future, or how do we go forward? Teletherapy in the mainstream care? Further studies are absolutely necessary here, which also confirm the effect. Legal anchoring even after the pandemic is an advantage. The internet has a different aspects, distance, but at the same time also through interaction with a virtual counterpart, some people have more opportunity to open up and be themselves. The acceptance of patients and therapists for teletherapy should be promoted. Face-to-face therapy is still considered the gold standard, but in the field of voice disorders, this has been refuted. On the one hand, the implementation of teletherapy during a global pandemic has been a driving force for change. On the other hand, it poses new challenges as how it might continue and subsequently evolve in an effective manner. Teletherapy facilitates some extras in terms of what can be picked up from the patient, as both audio and video are included. Teletherapy shows the authenticity of patients' vocal patterns, at home or at work. The attitude is different in a familiar environment, sometimes positive, sometimes voice burdening. Here is a chance to see a deeper insight. Teletherapy is a service model and not a therapy method or therapeutic approach. Telepractice is clearly here to stay and needs to move into a mainstream of clinical practice. We can continue to use and transform the experiences we are currently experiencing and bring them into a new future of therapeutic possibilities, based on evidence. With another wave just around the corner, why not take the plunge and offer voice therapy sessions online? It will work. Thank you very much.